inflammatory cells, polymorphonuclear cells or PMNs, macrophages, RBCs, and protein into the interstitium. There is formation of an intraalveolar hyaline membrane. Neutrophils cause destruction of type 1 and type 2 pneumocytes, which triggers a loss of surfactant and then leads to atelectasis. This causes the formation of an intrapulmonary shunt, a VQ mismatch with no ventilation. Pathogenesis of ARDS. Capillary endothelial damage plays a major role in the pathogenesis of ARDS and is the most important step. A tabular formulation of this mechanism includes sepsis, diffuse pulmonary infections, gastric aspiration, mechanical trauma, all cause a direct release from the circulation or an indirect release by resident alveolar macrophages secondary to pneumocyte injury of cytokines. These include TNF and IL-1. This leads to, number 1, pulmonary endothelial damage, and number 2, pulmonary endothelial activation. This then triggers the activated endothelial cells to express adhesion molecules, procoagulant proteins, and chemokines. This then leads to adhesion and extravasation of neutrophils into the interstitium and alveoli. Neutrophils degranulate and release inflammatory mediators. The proteases that are released digest proteins. Reactive oxygen species cause free radical damage. Cytokines perpetuate the inflammation, and macrophage migration inhibitory factor MIF sustains the ongoing pro-inflammatory response. These four mechanisms then again trigger pulmonary endothelial damage and pulmonary endothelial activation, and the cycle continues. Once these have been released, they trigger increased recruitment and adhesion of leukocytes. This mechanism then leads to three conditions. There is more endothelial damage, there is pneumocyte damage, or local thrombosis. When you have more endothelial damage, the pulmonary capillaries get leaky, and interstitial and alveolar edema occurs, and this interstitial and alveolar edema can be picked up as infiltrates on a chest x-ray and also causes dyspnea. This ultimately leads to reduced ventilation with normal perfusion, and there is a ventilation-perfusion mismatch. The second mechanism leading to pneumocyte damage causes less gas exchange, which damage to type 1 cells, and less surfactant, which damage to type 2 cells. Both of these then lead to alveolar collapse, which also causes a VQ mismatch, and there is also inspissated protein-rich edema fluid and necrotic cell debris which organize, and these cause the hyaline membrane to form, and this again triggers the ventilation-perfusion mismatch, the reduced ventilation, and normal perfusion. This ultimately leads to intrapulmonary shunting, which triggers hypoxemia, causing cyanosis, and ultimately respiratory failure. In ARDS, which happens beyond 7 days, the inflammatory stimulus slowly lessens. This happens because the macrophages remove cellular debris. They also release fibrogenic cytokines such as transforming growth factor beta, TGF-beta, and PDGF, a platelet-derived growth factor. This then triggers fibroblast growth, collagen deposition, ultimately leading to fibrosis of the alveolar wall. The bronchial stem cells proliferate to replace the pneumocytes, and uninjured capillary endothelium proliferates to restore the endothelium, and this triggers resolution of the ARDS finally. Morphology. DAD, or diffuse alveolar damage, is a characteristic histological manifestation of ARDS. In the acute stage, the lungs are heavy, firm, red, and boggy. They exhibit congestion, interstitial and intraalveolar edema, inflammation, fibrin deposition, and diffuse alveolar damage, or DAD. The alveolar walls become lines with waxy hyaline membranes. Alveolar hyaline membranes are eosinophilic and glassy and consist of fibrin-rich edema fluid mixed with cytoplasmic and lipid remnants of necrotic epithelial cells. Hyaline membranes appear by the second day and are the most conspicuous morphologic feature of the exudative phase after 4 to 5 days. In the organizing stage, type 2 pneumocytes proliferate vigorously in an attempt to regenerate the alveolar lining, and granulation tissue forms in the alveolar walls and spaces. In most cases, the granulation tissue resolves, leaving minimal functional impairment. Sometimes, however, fibrotic thickening or scarring of the alveolar septa ensues. Fatal cases often have superimposed bronchopneumonia. The clinical course. There are 3 phases in the natural history: exudative phase, proliferative phase, and a fibrotic phase. In the exudative phase, There is a characterization by alveolar edema and neutrophil inflammation with subsequent development of hyaline membranes, which are eosinophilic and glassy, and they cause the diffuse alveolar damage. The alveolar edema, which is the most prominent in the dependent portions of the lung, causes atelectasis and reduced lung compliance. The duration of this phase is typically up to 7 days in length and usually begins within 12 to 36 hours after the inciting insult. Hypoxemia or cyanosis, tachypnea, and progressive dyspnea are developed, and increased pulmonary dead space can also lead to hypercapnia or hypercarbia. Late inspiratory crackles can be heard on auscultation. Respiratory failure frequently develops during this phase. A chest X-ray reveals bilateral, diffuse alveolar and interstitial opacities. Common differential diagnosis includes cardiogenic pulmonary edema, pneumonia, and alveolar hemorrhage. Unlike cardiogenic pulmonary edema, the chest X-ray in ARDS rarely shows cardiomegaly, pleural effusions, or pulmonary vascular redistribution. The second phase, the proliferative phase, this phase typically lasts from approximately day 7 to 21 after the inciting insult. Interstitial inflammation and proliferated type 2 pneumocytes persist, but hyaline membranes are no longer formed. Alveolar macrophages digest the remnants of the hyaline membranes and other debris. Although most patients recover, some will develop progressive lung injury and evidence of pulmonary fibrosis. Even among patients who show rapid improvement, allowing removal of mechanical ventilator support, dyspnea and hypoxemia often persist during this phase. In the third and final phase, the fibrotic phase, most patients recover within 3 to 4 weeks of the initial pulmonary injury, but some experience progressive fibrosis necessitating prolonged ventilator support and or supplemental oxygen. There's an increased risk of pneumothorax, reductions in lung compliance, and increased pulmonary dead space observed during this phase. Remodeling of lung architecture produces many cyst-like spaces throughout the lung, or a honeycomb lung. These spaces are separated by thick fibrous walls lined by type 2 pneumocytes, bronchiolar epithelium, or squamous cells. Clinical features. Patients destined to develop ARDS have a symptom-free interval